In injecting the shoulder injections can be done either in the sitting position or the prone position. I personally prefer the prone position because when people faint, it's easier to pick them up from laying down than from sitting up. But in any case, many people do their injections in the sitting position, and some of the injections we want to do in the sitting position. We've carefully palpate the clavicle, keeping in mind that when we find the AC joint, we can mark that, inject it. That the coracoid process, we find the curve in the clavicle and come down a finger breadth and out a finger breadth, and we'll be on the coracoid process right there. You can feel his coracoid process. And we know that the ligaments that come into or through this area underneath attach then to the humerus out here. The subscapularis blends in over the short head or the long head of the biceps as it comes up and attaches to the glenoid up in here. In order to expose the tubercle and the attachments of the supraspinatus coming out of the area underneath the clavicle and acromion process, we find that groove between the acromion and the clavicle. And then we have the patient bring their arm back behind them like this, and that brings that tubercle out from underneath the acromion process and allows us to inject better onto the head of the attachments of the supraspinatus coming underneath that area. And we can palpate in this area and inject tender areas all around that area. Okay. The attachments of the greater tubercle, if we feel that we can't hit them adequately from this position or from the prone position, we can have the patient lie down with their arm propped up, and this will protrude the greater tubercle and allow us to get to the attachments of the infraspinatus in a more ready manner. Okay, we'll stop and have you lay down. Go ahead. In attempting to inject the lesser tubercle, the attachments of the supraspinatus, it's often good to again identify our landmarks. We can see the acromion, the edge of the acromion process here, the clavicle, and this subject has a very broad distal clavicle. The space between the clavicle and the acromion, which is our entry point for the glenoid, and the attachments of the long head of the biceps to inject the SLAP or the superior labral anterior posterior tear lesions. And so we can bring the arm then behind the back and putting the arm in internal rotation. That then brings that lesser tubercle out from underneath the acromion and puts it right in our needle line just below the acromion right here. In this manner, we can more effectively address the attachments of the supraspinatus coming under that acromion process. Okay, the clarity.
I like this.
Mm-hmm.
Does that look okay?
Bow.
Sorry, let me start you again. I was just checking focus. Okay, and go ahead.
In this position, with the patient up on his elbow, the greater tubercle and the attachments of the infraspinatus are elevated and protruded so that it makes that injection easier to do. The injection into the inferior part of the posterior glenoid is accomplished by placing the patient in the prone position with the arm either hanging off the table or down at the side, and then coming in below the spine of the scapula, and just distal and deeply to that, we press in. There's a space here. And people often have a lot of tenderness in that area at the attachments of the glenohumeral ligaments onto the posterior glenoid. We go right down into that space, injecting in a medial direction until we hit the glenoid, and we can walk along the glenoid, which is not a big space here, to inject the posterior capsular area and the glenohumeral ligament in this area. Okay, we're going to look at the anterior part of the shoulder now, and landmarks to identify, obviously the clavicle. We come out to the hook of the clavicle where the clavicle turns, and it's quite prominent in just about everybody. We find the hook of the clavicle right there. If we put our finger directly in the hook of the clavicle, and you can feel it just as a depression there, and then we come down a centimeter and out a centimeter, we'll be right on the coracoid process, or down a finger breadth and out a finger breadth. And there's the coracoid process right there. I think that this injection is easiest in the supine position. All of these injections can be done in different positions, and you'll see people in the prolotherapy world doing them in their favorite way. But again, we're down a finger breadth and out a finger breadth, and there's the tip of the coracoid process. The tip of the coracoid process is very important because of the short head of the biceps, the pectoralis minor, and the coracobrachialis that attach there. It's often exquisitely tender in people, and so it's good to come in and inject that and inject around the coracoid. We then can come up. We know the clavicle is coming out here, like so. And so we know that the acromioclavicular ligaments have to be above the coracoid process, and they fan out and hook onto the clavicle right here, and then the coracoacromial ligament comes out and hooks on the acromion process. Our next line is just distal to the coracoid process right here, and we know there's a depression there that gets us into the glenoid and the humerus on the other side. The attachments of the subscapularis coming across and blending in with the capsule of the joint that comes over onto the humerus, and down inferiorly the coracoglenoid ligaments, or the humeroglenoid ligaments, that helps stabilize the shoulder. So we have a line of injection in this area, getting the glenoid and those ligaments of the subscapularis coming across, and then a second line of injection coming down the shoulder, down ultimately into the pectoralis major, down the humerus, the tubercle right here, which is often exquisitely tender, and so this whole area really needs to be covered with injection. So our injections are done in this position with the arm laying out in the supine position. That rolls this humerus out and tends to give us better access to the ligaments in this area. We come directly into the coracoid again with our fingers on the coracoid process, so we depress the area coming down. It's a very shallow injection. Then we can slide our needle up onto the top of the coracoid process and go in a little bit inferiorly, caudally, and hit the top of the coracoid, injecting the coracoclavicular ligaments. Sometimes they're quite a ways in underneath the clavicle, and we need to walk our needle back onto the coracoid process. An alternative way to inject these is to aim the needle upward and come on the underside of the clavicle. Some people do this routinely. I choose to do just the lower side, since that space between the clavicle and the coracoid process is not large. And I've also experienced some people having severe pain with the injections up under the clavicle, so I choose to do my injections just onto the top of the coracoid process. My next layer of injections are just beyond the coracoid, coming in again to the glenoid here, and then down the humerus, the lesser tubercle, and down the humerus all the way down the pectoralis major, attaching right down the arm. One can also do the AC joint from this area, and we can outline that, or you can do it in the sitting position. Again, most of these injections can be done in more than one position. There are people who routinely do shoulders in the sitting position, and here's clavicle coming out here, and the AC joint feels like it's right in that area. So we're going to we're going to inject all the way around the joint, feeling tender areas and walking right around that AC joint. If you wish to slide into the joint, you need to aim medially to slide down into the joint. I don't do that because I assume that if I'm in the capsule, I'm going to bathe the joint and get fluid into the joint anyway. Sometimes people in the shoulder have discomfort down the deltoid, and there'll be particular areas. There's the acromion right here, particular areas down the deltoid where they will point to, where they have pain, and it's perfectly safe to go right in onto the humerus and inject those painful areas right along there. So the posterior shoulder, we're looking at the acromion process, which we can feel the angle of right there. We then drop down a centimeter, and we find a hole right here from the acromion process, and this is our entrance in, one of our entrances into the shoulder joint itself. We then feel the coracoid process in the front, and we aim our needle directly into that space for the coracoid process, and this is our intra-articular injection into the shoulder joint. We can come down into the posterior part of the shoulder, and often people will have on the lower part of the glenoid an exquisitely tender area. And you can put your thumb in right in that hole and hit that exquisitely tender area on the glenoid, and keeping your finger on it, come directly in to that spot under your thumb. Walking around on the glenoid, the posterior part of the glenoid, this is part of the posterior capsule. Some people do injections onto the humerus as well, either from this angle or from a prone position with the arm up a bit. Another injection done from this position in the sitting position is that between the clavicle and the acromion process. And this is the injection directly down in that angle between the posterior clavicle right here and the acromion process right here. And where those two meet, we're coming directly down onto the superior part of the glenoid. Our injection is directly downwards, perpendicularly, and we're coming down onto the superior part of the glenoid where we have the slap lesion, superior, labral, anterior, and posterior, where the biceps, head of the biceps can get torn off in various ways from the glenoid labrum. If we come down and hit the glenoid, do our injection there, and then we can angle our needle a little bit laterally, like this, toward the outer part of the shoulder here, angling our needle out in this direction. We can then come in and do an intra-articular injection through that same needle site. The anterior part of the shoulder, we remember the angle of the clavicle, this curve in the clavicle. And if we put our finger in that curve of the clavicle, and then we come down a finger breadth and out a finger breadth, the tip of the coracoid process always will lie in that area. It's a very constant anatomical finding. Then we come, so we come in with our needle onto the tip of the coracoid process, the attachments of the coracobrachialis, the short head of the biceps, and the pectoralis minor. And then we walk up the coracoid underneath it to catch the coracoclavicular ligaments. And again, this is not a big space. And so I walk up the underside and hit the top of the coracoid, sliding in underneath the clavicle into those ligaments. The coracoacromial ligament comes off a little further and up to the acromion process, and we can also catch that with our injections on that coracoid process. Some people inject up under the clavicle. I don't find a need to do this, and I usually just stay on the coracoid process. Our next injection is just off the coracoid process onto the glenoid, which is not a large area here, and the anterior capsule attaching in that area. We then move over onto the lesser tubercle right here and pepper the lesser tubercle quite well, moving down if it's tender down onto the humerus. We're also catching the subscapularis coming over with the anterior capsule attaching in that whole area. The glenohumeral ligaments also attach in here. If we wish, we can then come up onto the greater tubercle and the muscle attachments, tendon attachments on the greater tubercle, marching right back on the posterior part of it. And again, marching down the humerus, the pectoralis major attaching right here, which is often exquisitely tender right down that area. Coming into the posterior shoulder, we mentioned finding the curve of the acromion process and then entering the shoulder joint just a centimeter down from that, heading toward the coracoid process, and we're right into the shoulder joint here. And then the area down in here on the inferior part of the glenoid, the glenohumeral ligaments attaching in there, again often an exquisitely tender area right in that hole there that you come into, and it's fairly easy to hit that inferior part of the glenoid, and people will tell you when you're on that spot that's tender in that area, kind of peppering that whole area there. We mentioned the coming into the top of the area between the acromion process and the clavicle here. And so our injection is directly down in there, and we're down onto the top of the glenoid. Move this down like this, and I think we can see that, so that we can come down like this. We're right on top of the glenoid here, the slap lesion where the long head of the biceps comes in and attaches to that glenoid. And so if we drop off that, then we're right in the shoulder joint, and we can do an intra-articular injection from that spot. So coming down, we're on the glenoid right there for our slap lesion, and then we can come just off it into the shoulder joint itself.